Thank you. We are now reconvening back in public session. Thank you for your patience. We have a couple of resolutions for the committee today. The first one is regarding Medicaid and Medicare reimbursement consulting services. Uh, Mr. Hart, would you please lead us through the presentation?
Yeah. For authorizing the New York City Health and Hospitals Corporation, or the system, to execute contracts with third-party reimbursement solutions, LLC, Forvis Mazars, LLP, Baker Tilly Advisory Group, LP, formerly Moss Adams, and Manat Health Strategies, LLC, for Medicare and Medicaid reimbursement consulting services at a not-to-exceed amount of $10.8 million, which includes 20% contingency, for a contract term of 3 years and 2 one-year renewal options exercisable at the discretion of the city. Next slide. So for background, Medicaid and Medicare reimbursement consulting services are essential services used by all healthcare systems to ensure compliance with complex and often changing regulations regarding Medicaid and Medicare reimbursement and reporting. Timely and accurate submission of those reports are required to avoid penalties and secure proper reimbursement for the system. Consultants in this space assist the system in optimizing available reimbursement rates and settlements, and particularly of importance as a public safety net system, provide advice and assistance regarding supplemental funding streams that are available to us. For background on our use of these services, the RFP consolidated several previously solicited reimbursement scopes of work, incorporating services that had both been contracted directly by the reimbursement department, as well as additional services related to supplemental Medicaid and consolidated fiscal report submissions that were obtained through other departments' contracts. Consulting services procured through this RFP include the following scopes: under the umbrella of Medicare reimbursement and reporting consulting, general Medicare reimbursement analysis and cost report support, Medicare appeal support, Medicare DISH and uncompensated care reporting and policy, and under the umbrella of Medicaid reimbursement and state reporting consulting, general New York State Medicaid reimbursement, rate analysis and appeal support, specific long-term care reimbursement focus, supplemental funding, Medicaid funding, and innovative payment policy modeling, and consolidated fiscal reports submissions. The next slide. So this is the history of our use of these services in recent years. The reimbursement department previously entered into 2 agreements for Medicare-related consulting services. Those were with third-party reimbursement for Medicare general reimbursement and cost reporting support. The contract was initially awarded via an RFP for a term running from November 2019 through November 2024, and a not-to-exceed amount of $2 million. Subsequent amendments to that contract expanded the scope to include additional resources and extended the expiration date to December 31st, 2025, with a total contract value of just under $4.1 million. The second contract was with Moss Adams, which has now been acquired by Baker Tilly, for Medicare DISH and uncompensated care consulting services. That was also awarded via RFP for a term running from November 2019 through November 2024, and had a not-to-exceed amount of $2.2 million. Subsequent amendments to that contract extended the expiration date to December 2025, with a total contract value of $2.7 million. So the combined not-to-exceed amount for these 2 agreements is $6.8 million, and spend to date has been just under 6.1. As I mentioned, we additionally received services since FY21 totaling almost $2.8 million for Medicaid supplemental payment support and consolidated fiscal reporting submission support through other vendor agreements with other department vendor agreements with Manat Health Strategies, LLC, and Forvis Mazars. The next slide. So for the RFP, the minimum criteria was at least 5 years in business, relevant experience working with hospitals in healthcare financing and reimbursement, at least 10 employees, and annual revenue of at least $2 million in each of the last 3 years. The evaluation committee included representatives of Central Office Finance, Reimbursement Department, our Revenue Cycle Services Department, and the CFOs from post-acute care and one of our acute care hospitals. The criteria that the committee used to evaluate the vendors were 25% based on vendor experience, 25% on technical qualifications, 25% on ability and feasibility of meeting the scope of work, 15% on cost, and 10% on meeting MWBE targets. So we were approved by the CRC to issue this RFP in January of this year. As a result, we received in March 10 proposals. The committee completed evaluation of round 1 on the written proposals in April, and in May invited 4 vendors to present in oral presentations. Final scoring based on the second round was completed in June. So based on the scoring, the system will negotiate contracts with the top 4 scorers across all subscopes of work. Subject to negotiation, our contracts will specify primary scopes of work for each vendor, but will also provide flexibility for the system to assign vendors work in other areas of expertise as needed. So the 4 vendors and their primary scopes are as follows. Third-party reimbursement solutions with a primary scope focused on Medicare, general reimbursement, cost reporting support, and Medicare appeal support. Baker Tilly, which has said acquired Moss Adams, focused on Medicare DISH and uncompensated care and Medicare DISH appeal support. Forvis Mazars, focusing on Medicaid general reimbursement, long-term care issues, and consolidated fiscal reporting. And Manat Health Strategies, focusing on Medicaid supplemental funding and innovative payment policy models. So these are all vendors that we have experience with, and they all have scored excellent on their evaluations. The vendor diversity team set a goal of 10% diverse vendor participation for this solicitation. Forvis Mazars met that target through a subcontractor, Healthcare Management Solutions. The other 3 vendors were provided a waiver based on self-performance of the scope. So again, the request to the committee is authorizing the New York City Health and Hospitals Corporation to execute contracts with third-party reimbursement solutions, Forvis Mazars, Baker Tilly Advisory Group, and Manat Health Strategies for Medicaid and Medicare reimbursement consulting services at a not-to-exceed amount of $10.8 million, which includes a 20% contingency for a contract term of 3 years and 2 one-year renewal options exercisable at the direct discretion of the system. Happy to take any questions.
Thank you. Are there questions or comments from the
Just
committee?
a quick question. $12 million is not a particularly large contract, so for us. So I was wondering whether any one of them could do all the work, or there was an added advantage to having the work parsed out among them.
Yeah, like I said, we combined this RFP, combined a number of scopes into this RFP for the first time. We've previously solicited separately, and it was with the anticipation that potentially one vendor could take multiple scopes of work, and we did. There are really 7 sub-scopes of work, so some vendors do have more than one here. And we had, I believe, 10 proposals. 6 of the proposers did propose all scopes of work. In the end, based on the scoring, there really were standout specific expertise among the vendors. So we wanted to have that, best in class in each of the areas. I think we'll evaluate over time, and that's also a reason why we wanted to have flexibility in the contracts to, maybe parse some pieces out and see how vendors do. And potentially in the future, we could further collapse.
Okay, thank you.
Any other questions? Okay. If there's no other questions, I would like to propose a motion to approve this resolution.
So
Any
moved.
second? Second? And all those in favor?
Yes.
Yes. Any opposed? Okay, the resolution passes. Thank you. The next one, Ms. John Teff, please read the medical respite operations and services not to exceed amendment request and proceed with the presentation.
Authorizing New York City Health and Hospitals Corporation, the system, to increase the funding by $10,896,459 for its previously executed agreements with each of the Institute for Community Living, Inc., ICL, and Community Life for the provision of medical respite beds and services, such that the funding is increased from $17,960,500 to $28,856,959, thereby funding the increase in capacity of the program from 51 to 75 beds. Good morning. I'm here with my colleague Marjorie Montplaisir Ellis from the Housing for Health team. Today we're briefing you on a contract adjustment for the medical respite program, which is an essential part of the Housing for Health program. You've seen the slide before you previously when we speak about Housing for Health and other contexts. Housing for Health connects our patients experiencing homelessness to housing supports and opportunities in order to stabilize their lives and improve their health. These patients are medically and socially complex, and Housing for Health provides an access point to housing from the healthcare system. Next slide, please. Patients experiencing homelessness have long and complex inpatient stays, and even when medically cleared for discharge, have no safe place to go to recover and heal, and oftentimes shelter is not an option. Yet after a hospital stay, patients experiencing homelessness are more vulnerable. Medical respite is one solution. It offers a safe place in the community with access to home-based clinical services. It is one of the system's initiatives focused on reduction of length of stay. Medical respite is an interim housing option with services that include an on-site RN, home-based PT/OT, connections to care, and housing navigation support. This is essential so that patients can stabilize and then move on to housing. Today, we contract with 2 vendors who have grown and evolved with us since their contract in 2022. They meet the needs of our patients who are increasingly more ill. Medical respite serves approximately 400 patients per year with an average length of stay of 73 days. Next slide, please. Medical respite offers significant benefits to the system and to patients. For the system, it reduces inpatient length of stay who no longer require hospitalization, but in a cost-efficient way. It also improves access to hospital beds for new admissions, allowing the system to generate revenue. Based on our conservative estimates, the annual projected net revenue meets the program's operating costs. Next slide, please. We've also seen positive patient outcomes after their stay at respite. We looked at their healthcare utilization of a small cohort using our EMR. We've seen a reduction in the utilization of the ED, reduction in the number of med-surg days, and reduction in inpatient psych days. We've also seen an increase in outpatient visits. Medical respite has also been a great launch to stable housing. We are in the process of evaluating the cost savings associated with our housing programs for risk-attributed patients. Next slide, please. In 2024, we had 4-week-long wait lists for respite. This converged with high census at our hospitals as well as sicker patients. Patients were waiting to discharge from the hospital for respite, lengthening their hospital stay. We also saw a significant impact of the Beth Israel closure on Bellevue. We had an opportunity to expand the program and add more services to meet the system demand and patient acuity. We added more beds and therefore expedited the spending of the existing contracts that were signed in 2022. In order to continue to the remaining 2 years of the contract at 75 beds, the program needs an additional $10.8 million. And I'll pause for questions. I can reread the authorization. So we are here today to authorize Health and Hospitals to increase the funding by $10.8 million.
That's okay. You don't need to read again. Thank you.
I wasn't sure if you got
Thanks, Leora. So thank you for the presentation. Does the committee?
I remember when you first joined us to create our housing initiative, and you've grown it just exponentially. It's been tremendous. And the ability you've had to place formerly homeless people into permanent housing, to provide needed medical attention, psychological attention. I don't think we could have anticipated offshoots. I'm wondering whether at a point, maybe you're already doing this, it makes sense to take a look back, to do some like individual audits of different programs and look at what's worked, what we might want to change, what's been most productive, things like that.
Yeah, I mean, I think we're at the point now where we're working closely with finance to look at the just sort of actuarial savings. But in terms of operational savings, we keep thinking how to be more efficient in taking referrals from the system, where are intake points for housing navigation services, how can we work more closely with people who are inpatient as well as people that are getting referred to us from the outpatient safety net clinic, for example. So we continue to fine tune our operations, and we also continue to work very closely with our sister agencies. I think we cannot do this in a bubble. We're part of a larger integrated housing and homelessness system, so work very closely with DSS, HPD, HRA, DHS. So I think those are the kinds of things that we continue to evolve.
Leroy, oh, I'm sorry, Trustee Hugo.
It's amazing effort, and what I'm looking at is the cost per bed, and if I estimated that correctly, it's like $350K for a bed, and that's going up to $380K. Am I looking at that right?
When we first signed the contracts in 2022, it was actually a little bit under 200 per bed per day. And we anticipate for the last 2 years, it's going to be 250 per bed per day. And we've seen a couple of things make that change. One, real estate costs go up over time. We've also had patients that are just sicker. So we've had to ask our vendors to add more clinical supports on site. And initially, we didn't require an on-site RN and things like that. So there's been adding more to the services on site. So it should be for the last 2 years, 250 per bed per day, and the first 3 years were a little bit less.
Okay, so $250 per bed per day, and I just did a calculation where it was like $350. So what's the differential?
I have it at 250 for the last 2 years, so we can go back and check. That's what we are anticipating for our budget. Part of it also, and I think this is positive news, we haven't yet spent down the original 2022 contract. We're at a point for December 1st to exercise our 2 one-year options. And the prudent thing to do is come to the board prior to exercising that option to make sure that we're getting the last 2 years fully funded. So there's still residual money rolling into what I would say probably 30% of the 4th year. But in order to exercise our option, we needed to properly come to the board and ask for the full amount. But I'm happy to look at it again after, and I can correspond to make sure that the math aligns.
Yep, thank you.
I would just also mention, right, the other comparison point is for that same person, they may be in the hospital at $2,000 a day. Right, so that's the savings we're trying to pick up. Plus, right, the patient doesn't really need to be in the hospital. We're just trying to find another safer location, transition bed for them. So that's the actuarial analysis that we're going to do. We're really going to study this, pretty carefully, and we think it's actually pretty cutting edge in some ways. So.
I think this is the resulting backfill capacity valued approximately $6 million, and is that a kind of gross approximation of?
That is based on a very conservative approach of anticipating backfill revenue.
Oh, that's for opening up the beds.
Correct.
Okay, that's not even the
that's
cost savings from the patients themselves.
That's correct. That is just the opening of the beds.
Yeah.
There's also savings in terms of this patient population we know already are coming to ED less frequently.
Right. Exactly.
And we know that they're having shorter inpatient stays. And so that alone has other savings.
Yes.
We haven't, that math is in progress.
Right.
John and Sasha and other folks are working on that. But we just did a very conservative estimate to say that the backfill revenue alone annually should be sufficient to cover the annual cost for the program. And we feel good with that conservative estimate.
Right.
Two thoughts. First, what you're doing is in bringing this today with the higher amount is solving the NTE problem.
Correct.
I just want to be clear, right, that one of our things was we said to solve the possibility of, for successful programs where they are growing, right? And we're all happy that they're growing ahead of time so that you can approve an increase. So this is part of that. And then just to start one step behind, the real goal is to be able to demonstrate for some population why Medicaid should pay. Right, so for everybody to understand, we get paid the $2,000 for the day. We do not get paid the $250. So so one of the things that's critical on the financial analysis is whose money are we talking about? Right. So this is not necessarily saving us money.
It's saving
It's saving the system money.
the medical system.
Now, there are exceptions. For example, if someone doesn't have a payer, if somebody's it no longer has an approved day pay because they're beyond their. So it's all sorts of different levels on which this program works. So somebody could be an undocumented person and in our hospital. Well, in that case, maybe it is a huge savings, right? But the real goal here, and just to say in the analysis, you're not even necessarily have to prove that the whole program saves for Medicaid, because most Medicaid programs have eligibility. So you could find that the people for whom the program saves money are people in these categories. Even if the whole program didn't save Medicaid money, we could imagine, because ultimately what I would want to do is to be able to go to the state and say, this is a program to decrease hospital expenses. But I have to be able to show them, right, in your analysis. And I'm just saying that there's the whole pool analysis, but you could also, if really when you look at the data in the granular way, the real savings comes if the person's over 50, if they have more than 3 conditions, right, then you could imagine how that leads to an eligibility requirement under Medicaid, that Medicaid will pay for this. So, I mean, I think that it's incredibly exciting. I know the partners love working with you, right? One of the groups had just released a very lengthy report about the success of respite, and what I think of as the chief, the special ingredient is flexibility. Right, that's how respite is in some ways different than a phenomenal program for pregnant women with opioid use, right? This is a program that works pretty much for everybody, all comers who are stuck in the hospital, and I think begins with what does the client need? And in that way, it really meets our patients where they are. So I think that's to your success and the success of the team.
Thanks.
I
Just
think,
following up on Mitch's question, your point, the 70% placement rate is extraordinary. Do you think it's because of the treatment while in respite? Do you think you get patients who are healthier when they come into the program?
I think it's 70% of people who are eligible for housing. As you
Right.
know, the eligibility for supportive housing is quite complex. We think, as Dr. Katz pointed out, we have very flexible partners who have housing portfolios, so that has helped. Also, good collaboration with our sister agencies. I think nobody wants people who have spent 4 weeks in the hospital, who are particularly vulnerable, and then 70 more days recovering at respite to really return to shelter. We've invested so much time and effort. So I think there's a collective understanding with our colleagues, this is the right path. And we've had very flexible partners, but it's administratively intensive to move someone from any spot into supportive housing. And most people are 100% going to supportive housing.
Right. Thank you.
I think suffice it to say, there's a lot of interest from the committee to see the actuarial study and the reports, and as you're making the case to the state and for coverage and reimbursement, all of those things. It's a wonderful program. Clearly, the statistics that you've provided prove the value and the need and the success. So, Thank you, and thank you for getting ahead of the NTE. That is something we have been very focused on, so appreciate that
Rita,
too.
can I add?
Oh, sorry.
One quick comment on the quality of life side. You know, if you're able to capture quality of life or anything around that, not just a financial calculation, but I think you'll make even a stronger case that this is important for this patient population.
Thank you. Great. Then I'll take a vote. All those in favor, well, I guess I'll make a motion.
It's not a not to exceed
Oh,
of
sorry.
10.9, it's additional funding of 10.9.
For a total not to exceed of 28,856.
Is it increasing the funding or increase the not to exceed by 10.9?
We were at risk of violating the prior not to exceed of the contract. So they are increasing the current the current amount of the contract by 10.896 million
Not the not
for
to
a
exceed.
new not to exceed of 28.856 million.
Okay.
So, did I get that right? We are, okay. So that is the motion on the table. Do I have a second? And all those in favor?
Yes.
Any opposed? Okay, great, the resolution passes, thank you very much. And next, we are running quite a bit behind, so I apologize for that. We do have a brief financial update, if you guys could
We'll go quick.
try to do it in quickly, yes, thank you.
I think first, thank you for the time. First, I'd say I think the system's stable and doing, I think, very well, hitting most, if not all, of its financial metrics. We've completed the closeout of FY25, and we closed out June with $650 million in the bank. We beat the budget by 0.5% or $103 million. The year-to-year increase in patient care revenues up $959 million, which is a pretty significant number. Patient care volumes are up, inpatient discharges up 2.5%, outpatient visits 17%. Risk pool performance, even though we've forecasted a downward adjustment to the risk pools, it'll still bring in $634 million in receipts, or 76% higher than FY19. So very substantial performance in our risk-based contracts with Health First and Metro Plus. It's always worth it. Spend a minute, right? Just a minute to see where you've been. It does provide perspective. Our direct patient care revenues have surpassed $5.7 billion, and that's an increase of $2.5 billion since FY19. That was part of our strategy going in. We're seeing, growth in membership at Metro Plus, hitting 691,000, or an increase of 175,000 new members, at-risk members, providing, risk pool revenues for us compared to the pre-pandemic levels. I think these are the measures I think, even the finance people most proud of, is the fact that our H&H facilities, we fill up the top 10 Health First Network measures, right, compared to our colleagues, in the city. So those numbers you have to work hard at it. In my mind, it shows how the value-based, payment model we have is really working. The other is, our patients, right, are engaged with us, and within Epic, 85% of our in-panel patients are using MyChart. And I remember before the pandemic, we were trying to figure out how to get from 20 to 25, and thought, oh, we're never going to get there, right? But our patients, right, we appreciate them. They appreciate the care that they're getting, and MyChart gives them more control over the care they get. They can, order and have more control over their healthcare, and that's exactly what we want. Strategic financial incentives, over $1.3 billion against the FY25 target, and each of these areas that we watch very closely are surpassing their performance targets. So we're very proud of that. Looking ahead to 26, right, as we design the budget for this year, these were the major themes that we applied to construct the budget. Raising the bar in managed care and revenue cycle targets. We know, even though we've done a great job, we know that there's more to do. Really, the name of the game is patient access. We want to make ourselves more available to our patients and provide the care when they need it. cross-facility partnerships, and I think the further development of physician workforce planning is very helpful. Length of stay reduction investments, certainly within a capitated environment, very important. Metro Plus Health, Metro Plus membership, gold enrollment, we're pushing hard on that. Infrastructure investments, trying to find new monies for infrastructure all the time. And then, just continuing to take steps to stabilize the workforce, which I think since the pandemic, we've made great strides there. So those are our keys to success. James, do you want to?
On cash?
Yeah.
Sure. Yeah, so cash, we ended September at about $535 million or 17 days, which is, stable for us and consistent with where we expect it to be. Same goes for October, where we're looking at about $500 million. And, throughout, we're always working with the city on our cash flow, but we're planning to remain stable.
So we're always watching our, trying to manage risk, where we can. The next slide, please. This is our chart. We've done this before. We try to give you a level associated with the risk. All of these really stem from HR 1, or sometimes referred to as the one big, beautiful bill. The essential plan change was really, I think, going to be devastating, not only for health and hospitals, but I think for the New York State healthcare system in general. And what we learned last month is that the governor has come up with a strategy to restore most of the program through what's called the Basic Health Plan Trust Fund. So for those folks that have what we call EP, Essential Plan Coverage 1 through 4, those are different cohorts. They, under the governor's plan, will continue to receive, coverage. The EP5 group was the most recently added population with incomes up to 250%. We're still trying to assess that group and hopefully come up with solutions for them. But we believe, right, one of the bigger risks on the board, we think has been mitigated. We're still very concerned about the Medicaid work requirements and the 6-month recertification requirement. That doesn't start to in law, does not become effective until January of 2027. So we're trying to develop strategies and preparing for that, right? It's very important that these onerous requirements of going through re-enrollment, that we try to make it as easy as possible on our patients. We've received good news, right, from CMS over the past couple of weeks that what we call the average commercial rate or state-directed payment proposal that we had submitted the year 1 for the period July 1st of 2024 through March 31st of 2025 was approved. And that's very significant for us, and we appreciate CMS's working with us on that effort. Year 2 is still being reviewed, but we're very optimistic with the year 1 approval that year 2, in fact, will also be approved. But we'll have to wait and see until that's actually issued. We listed the HMO tax. The governor, the final budget included an HMO tax, where I think statewide there was an estimated $1.1 billion in various, rate initiatives. That was put on hold with HR 1. There is a 3-year transition period, and I know the state is negotiating with CMS to allow the HMO tax in some form to run its course for up to the 3-year period, but nothing definitive yet on that. And then on the government shutdown, we're not seeing any immediate effects of that because the Medicare, Medicaid appropriations are still available, and payments are getting made. The dish cuts, extending the dish cuts is something that we're continuing to watch and advocate for. So those are the major risks.
I'm
I'm
thinking, John, maybe there's some really great updates for the next sections. And I hate to do this, but maybe we can have a meeting in November to go over in detail. I don't know that these are time sensitive.
Nope.
So I wanted to give if the committee members have any comments or questions on what you've presented for FY25, the great performance we've seen there and all the accomplishments and what we're focused on for 26, obviously with all of the risks that you identified that are continually changing. So I appreciate that update. Any questions or comments from the committee on that? No, so thank you. I know we want to hit revenue cycle, we want to hit the,
We always come back.
wonderful VPP, performance and HERC, of course, but a successful bond issue, I know. So all of all of that information is in the packet, but I would like to have some time to talk about it, so we'll find another session. So thank you. Is there any old business or new business to come before the committee? All right, if nothing else, we are adjourned. Thank you.
Thank you.
This meeting is no longer being recorded.